Hi, everybody, and welcome to the HIV Quarterly Brief for Quarter 3 of 2023. Joining me today is Dr. Babafemi Taiwo, coming to us from Northwestern in Chicago. Welcome, Babafemi.
Thank you, Paul.
I am going to just start by making a few comments about something that did happen this quarter, and that was the IS meeting in Brisbane, Australia. And both Babafemi and I were lucky enough to get to attend. Babafemi, I thought it was a very interesting meeting with lots of fascinating data, almost like a return to pre-pandemic meetings of HIV. What do you think?
Absolutely. I really thought that there was still, despite research in HIV being gone, there still continue to be important findings, things that can really impact the lives of persons with HIV. That I felt was really rewarding.
Yeah. And why don't we start us off then and talk about Australia, and it's in some ways unique.
All of us are striving towards the UNAIDS goal of 90-90-90 by 2020. Only a few countries met that. But of course, we have the new target of 95-95-95 by 2025. And Australia really seems to be doing a terrific job, which is exemplary and was profiled to some extent at the Brisbane conference. Specifically, they reported on the epidemic there, where they have close to 30,000 individuals living with HIV, and reported that they had achieved the 90-90-90 by 2020. Specifically, the first 90, they had 91.1%, 91.6%, and then about 98% of persons were suppressed, who were in care were suppressed, which is really quite fascinating. And there's still room for improvement so that we can get to 95, 95, 95. But overall, really important results, and shows that the goal of 95, 95, 95 is just not a pipe dream.
Yeah.
But with certain efforts could be achieved.
I agree. And one thing, when you talk to clinicians who do HIV medicine in Australia, they comment, especially in urban areas, how rarely they see people who have recently acquired HIV. It's an amazing accomplishment. You want to stay in that area with prevention and tell us about feasibility of long-acting PrEP with cabotegravir?
Right. Long-acting PrEP with cabotegravir is something that we are all excited about, following the study showing superiority versus TDF-FTC. But the challenge that all clinicians have, and I suspect you have the same, Paul, in your practice, how do we really implement this? And so any opportunity to implement this modality outside of standard clinic environment will be, outside of a standard sort of a typical clinic environment, would be fantastic. And this is what was done in this study conducted in Washington, D.C. They were able to engage about 139 individuals. They gave them PrEP, gave over 300 injections. And at the end of the day, they demonstrated a few things. One was that retention of participants to receive PrEP in this way was actually possible. And also, they showed that you can actually administer the injections on time. And specifically, second injection, they had really reasonable rate, about 90%. But by the time you got to the second injection, by the time you got to the third injection, it had dropped to 63%. And so that is something that was noticeable. So what's the take-home message? We know that now this attempt to deliver long-acting CAB in a setting that is not, that actually has community health workers who are not medically licensed, was actually successful. And overall, there's room for improvement, but promising for the future.
So speaking of cabotegravir PrEP, HPTN 084 had some follow-up information. You want to summarize what they presented in Brisbane?
Right. HPTN 084, just to remind our listeners, was done in cisgender women, and that showed again superiority versus TDF-FTC. And the question really here was, what did the participants prefer, or what did they choose to go on to having after the study rolled over into the open label extension phase? And what the study really showed was that this is a strong, really strong preference for long-acting cabotegravir, with almost 80% of all the participants choosing long-acting cabotegravir. But another critical point is when the question about the reason underlying their choice was asked, the most common reason for that was preference of that modality that they chose, preference for the oral or preference for the injectable.
The last study I want to mention about cabotegravir PrEP is a case report that actually came from Chicago, describing a person who developed HIV while receiving cabotegravir PrEP. And here, someone who was on TAF-FTC for PrEP switched to cabotegravir for PrEP and ended up shortly thereafter, I think it was the third injection, developing having a positive HIV RNA, and it's really exquisitely described in the paper. You can see that he had injection number 3, and on that day, his HIV RNA was 1.48 log, so that's around 30 copies. And then his HIV antigen antibody test was negative, and they brought him back 9 days later, and his HIV RNA was 1.30 log. But then now his HIV antigen antibody was reactive, and his antibody was detectable. So at that point, they felt that they had a confirmed breakthrough. And then he got put on an ART regimen of darunavir, ritonavir, and dolutegravir, and he's been suppressed ever since. And I think the important thing to emphasize is that this individual now has a non-reactive antigen antibody test, an undetectable HIV RNA or viral load, and an undetectable HIV DNA. So even though HIV infection was established in this person, no one can now prove by standard testing that he has it. And even though these cases are very rare, this individual case highlights just how incredibly challenging the diagnosis and management of these breakthrough cases will be.
And this case speaks to the, perhaps I think, the importance of following the CDC recommendation, right? That certainly when administering this modality, we should test not just for antigen antibody, but also use an RNA test in following patients.
I agree. All right, shifting now to treatment-naive studies. Hooray, we finally get a treatment-naive study at a major meeting.
Right.
Study 020 was presented by Jürgen Rachstroh from Germany, and it was a comparison of bictegravir FTC TAF versus an investigational strategy of doravirine plus islatravir, the investigational nucleoside reverse transcriptase translocation inhibitor. And it turns out that at week 48, virologic suppression was non-inferior with the investigational strategy, 89% and 88% for bictegravir FTC TAF. One important point in these studies is that we're now used to bictegravir and dolutegravir studies having no resistance at all, and that was true here. But there was one patient in the doravirine islatravir arm who developed resistance to doravirine, and lymphocytopenia was observed in this study, more in the doravirine islatravir arm than in the control. And so the study is being repeated using a lower dose of islatravir. So overall, promising. I wonder what your thoughts are about this study.
Right. The study, I agree with you, was very promising. As you noted, the dose of islatravir used was 0.75 milligrams, which we know has been associated with lymphocytopenia. And so the lower dose that is being used is 0.25 milligrams. Now, in this study that used the 0.75 milligrams, we did see these two-class resistance mutations emerge. And so one would have to wonder what the results will be with the 0.25 milligrams, although I think that the earlier studies, the phase 2B studies, etc., showed that the 0.25 milligrams is really, really strong, and hopefully everything goes well. Time will tell.
Yeah, well, we'll see. I'm going to stick with two drugs therapy and going to talk about dolutegravir lamivudine, and I know you've been one of the pioneers of this regimen, and it's a study that looked at starting this treatment in about 220 people with treatment naive or so, and randomizing them to either dolutegravir lamivudine or dolutegravir plus tenofovir XTC. And the novelty of the trial is They just said, go ahead and start, and you don't need to check resistance testing, and let's see how it goes. And they did a week 24 analysis, even though the week 48 results are the primary endpoint. And at week 24, it looks very successful, both treatment arms. And there was nobody who developed treatment emergent resistance. I have some thoughts about this. I think probably the success of this regimen is due to the fact that transmitted 184V is very rare. I don't know that it will change my practice. What do you think?
No, it wouldn't change my practice because there are just so many patients who could benefit from this strategy that I would certainly, I don't think I will be using it as used in this particular trial, even though I think the results will be true for the vast majority of patients. But again, I may not use it necessarily as described.
So how about the ADVANCE study?
Yeah, that was interesting. You recall the ADVANCE study looked at dolutegravir plus TDF FTC versus dolutegravir plus TAF FTC versus efavirenz plus TDF FTC in treatment-naive participants in South Africa. Very large study, 1,053 participants did show non-inferiority, or the regimens were essentially comparable. But the question here was really very specific in that amongst participants who developed virologic failure throughout the 192 weeks of observation, what happened to them virologically while still on their randomized therapy? And then looking at 3 different regimens, they combined dolutegravir arms and found that 95%, a staggering 95% of the participants achieved resuppression to less than 50 without changing the regimen, compared to just 66% of the patients on efavirenz TDF FTC. This has had a significant impact on the treatment guidelines in South Africa, in that the rapid rush to switch patients off of dolutegravir plus 2 NRTIs is now strongly discouraged. It's recommended that the switch be made only when resistance against or resistance to dolutegravir is demonstrated.
Yeah, I think it's what we do in clinical practice. I will say that, in a land like South Africa, or where massive use of dolutegravir is taking place outside of clinical trials, they are starting to see dolutegravir resistance, but that's predominantly in not in treatment naive individuals, but it's in treatment experienced people, and they don't have fully active nucleosides, and their adherence is not so good. But in treatment naive, it's very rare. I am going to mention one other study quickly before we leave this treatment naive space, and that is the follow-up of the Alliance trial, which took a look at bictegravir FTC TAF versus dolutegravir plus FTC TAF in people who are treatment naive and have hepatitis B co-infection. And the 48-week data were published, and it suggested that the HIV results were not significantly different, no surprise, but the hepatitis B results looked better for hepatitis B suppression for the TAF intervention. So that's the bictegravir FTC TAF. And I think that it's worth looking at the 96-week results, because some of those advantages of FTC TAF for hepatitis B have now not worn off, but the TDF FTC has caught up, at least on the virologic suppression side. However, there still were some benefits seen with the TAF arm, and the rate of loss of e antigen and seroconversion was faster. So I guess the way I would look at this comparison is that even though TDF was first, and it took some proving that TAF would be a hepatitis B drug, I would say these data suggest that TAF FTC is at least as good, if not better, than TDF FTC for hepatitis B HIV co-infection. Okay, so on to the next study, and these are switch trials mostly, at least the combined trial, which I'll briefly mention. This is an observational study looking at switching to 2-drug therapy, not in clinical trials, but in clinical practice. And so it included 735 people. Most of them in this study switched to dolutegravir lamivudine, some to dolutegravir rilpivirine. And the important thing is that, unlike in the Tango and Salsa and other licensing studies, SWORD, Here, the people are just from clinical practice, so they could have a history of drug resistance or treatment failure. And indeed, many of them did, but nonetheless, the success rate was extremely high. It was, over 99% in dolutegravir lamivudine and over 97% in dolutegravir rilpivirine. So very successful. I do want to emphasize that this study did not advocate for using two drug regimens in people who have resistance to one of the two drugs, but it just shows that you can probably expand two drug therapy outside of the limited confines of what was in the clinical trials.
Oh, no doubt about that. And I think really for the majority of persons with HIV, two drug regimens will be okay. Well, integrase-based two drug regimens. So let's not generalize too much. The ones that are backed by evidence. And this is, again, one of the trials showing that. So congrats to the investigators once again.
Okay. Take us through the next switch trial, which is the SOLAR trial.
Right. The SOLAR trial basically looked at participants who were well suppressed on a bictegravir TAF FTC regimen and randomized them to switch into cabotegravir rilpivirine every 2 months or continuation of the bictegravir TAF FTC. We know that non-inferiority was demonstrated, but the question that these investigators posed in this particular report is patient-reported outcomes. In fact, 90% of the participants expressed a preference for big TAF for cabotegravir rilpivirine and also expressed significant satisfaction, etc. I guess one way to look at this study is that, well, this looked at a group of individuals who were probably at baseline interested in getting long-acting therapy. And so that absolutely is true.
Well, I agree with you that this study shows that the people who want to do this really like it. I do want to underscore something, though, that the people who are ambivalent or maybe don't want to do it, they should in no way be forced or encouraged to do this, because it's no picnic getting 2 injections every 2 months. And second, because there is a small but finite risk of virologic failure, and even in people who are adherent to the treatment. So now on to another long-acting treatment that is FDA approved, and that's lenacapavir. So short little blurb about a strategy in those trials.
During the trial, there was a problem that led to the clinical hold because of some issues with the vials, nothing with the drugs, but with the vials. And that forced investigators to switch participants from subcutaneous lenacapavir to oral weekly lenacapavir 300 milligrams. And now they went back to look at how this switch to oral lenacapavir affected outcomes. So number one, biologic suppression in both studies was not negatively impacted. Then they looked at about 11 participants who were viremic in the Capella study at the time of the switch to oral lenacapavir and did not see any worrisome increase, more than 1 log increase in the HIV RNA. So this is reassuring and really provides evidence that in clinical practice, it should be okay if one had to use oral lenacapavir as a bridge strategy in patients on subcutaneous lenacapavir.
So now on to a hot topic, which is a paper just published in Clinical Infectious Diseases, a journal for which I confess my very deep bias and one I think that you share. Anyway, this was a study of 12 people with HIV who had viremia despite oral ART, meaning they weren't taking it. First, they were 7 women, 5 men. Second, their CD4 cell count was average 233 and their viral load 152,000. And 5 of 12 had had previous AIDS-defining opportunistic infections. And then the last point I want to mention is that it was conducted in Mississippi and at a Ryan White-funded HIV clinic, so not in heavily resourced San Francisco. Despite these challenges, all 12 achieved virologic suppression. And at the end of when they submitted this paper, no one had developed resistance. My own feeling about this strategy is that, under limited situations where you really can't get anything else to work and people just can't or won't take oral ART, and they have advanced disease, if they have a virus that's susceptible to these two agents, they really should be offered this strategy because otherwise the alternative is untreated advanced HIV disease. And we know, given the pre-ART era, how terrible the prognosis was. Where do you think we're headed with this use of cabrolpivirine?
I think I read your opinion piece in Journal Watch. I saw that. So I know how you feel about it. I do think that there is room for this intervention for some patients. It's going to be all about patient selection and those who cannot or will not, as you described it, take oral therapy.
Yeah, I mean, it's the reason why I'm sort of harping on it is because the guidelines now specifically advise against it. And yet there is this small subset of patients for whom it is absolutely life-saving. We have 2 such people in our clinic, and it has basically, in my opinion, keep them out of the hospital and save their life. So take us through the biggest clinical trial, I believe, in HIV clinical trials history, and that's the Reprieve trial.
No doubt. No doubt. The Reprieve was the largest so far, over 7,000 participants, and really was designed to answer a very important question, which is the role of statin, pitavastatin in this case, in individuals for whom a statin would not have been a natural or sort of a prescribed medication. The study randomized them to pitavastatin versus placebo and followed the participants. This study was prematurely halted because of really important differences in the incidence of the primary outcome, which was major adverse cardiovascular events, which would include things like heart attacks, strokes, peripheral vascular disease, and also mortality. In fact, there was a lower occurrence of MACE amongst the participants randomized to pitavastatin versus those who got placebo. And when they looked at the combination of MACE plus mortality, there was only 21% decrease in the incidence of MACE plus mortality. So very important study, and I think it's no doubt going to impact practice. The other thing one will think about is it for everyone? Is it who is over 40, regardless of their ASCVD score at this point? It's a lot of debate going on, but certainly it will broaden the population that is eligible and should be prescribed statins to reduce the risk of this event.
All right, shifting now to everybody's favorite topic, which is weight gain. I have to have the privilege of presenting our very first randomized clinical trial of an intervention to reduce integrase inhibitor and TAF-associated weight gain. That was the study population, that they had people who'd increased by 10% or more their body weight on an integrase plus TAF regimen. And they were then randomized to open label darunavir, cobicistat, FTC TAF, 1 pill, or to stay on their current regimen. They met criteria for obesity, and nothing happened. Basically, the weights were the same. There really was no significant weight loss. I think you can interpret it a bunch of ways. My own view is the more data we see on this, the less I'm convinced that the integrases and TAF are directly causing weight gain. And the more I think is that we were dealing with a TDF-related weight suppression effect that we no longer see. And maybe there's other factors. I don't know. All I know is that so far our interventions involving ART switch don't look very promising. So you think this study is the end of the darunavir switch to a protease inhibitor for weight loss?
I think so. Just because darunavir before, prior to this, already had was not a first line preferred regimen, right? For some reasons. Exactly. And so any perceived or anticipated benefit was not demonstrated here. So we have to revert back to our fallback defensive position, really, in court, which is to just keep what we have while looking for what we don't have.
One other study on weight gain also comes from clinical infectious diseases, and that was a study of from the ACE clinical trials group. And it was led by one of our co-editors, Sarah Beres from the University of Nebraska. And in this study, which had, I think like 8 years of follow-up, median follow-up, they looked at an association between weight gain on ART and subsequent cardiometabolic abnormalities. And, no surprise, if people gain a lot of weight, over the period where they're on ART, they are going to actually get complications. But she looked at endpoints of diabetes, metabolic syndrome, a cardiometabolic event, and all of them were statistically significant for people who gained more than 10% on ART. So interesting paper.
Yeah, definitely. And I think as a clinician, the way I would utilize this data and encourage others to consider is to look at that first year following ART initiation as an important year where you're trying to calibrate and mitigate any potential long-term adverse effects. So I tell my patients, if you gain weight, please don't wait till your next visit when your weight, is already 20 pounds higher. You gain 5 pounds, let me know about it, because maybe we need to talk about your exercise, we need to talk about your diet. Maybe there are things we need to do early before we're now at 20 pounds and no one is happy.
I totally agree. One other study from, switching now to a different issue, and that's ART in pregnancy. I wanted to mention a small study because that was a very well done pharmacokinetic study, and that was the pharmacokinetic study of bictegravir FTC TAF in pregnancy. And these are some of the first data we have. And what the data showed is that in the second and third trimester, in the small number of women who participated, you actually do have a significant decline in bictegravir exposures. However, even though the levels are lower, the trough concentrations are still substantially above the protein-adjusted interquartile value required for inhibition of the virus in vitro. So the fact that there were no virologic failures in this study, because remember, they're also taking TAF-FTC, isn't surprising to me. So overall, these data I thought were reassuring. And my strategy, I'm very interesting to know what you do. When a patient in our clinic who's a stable woman with HIV on bictegravir FTC TAF comes in and says, I think miss my period, I think I'm pregnant, and they are pregnant, I don't necessarily push them to switch. I'm not sure what you do in your situation. I discuss the pros and cons, but I don't force the issue.
Right. I think in persons who are already pregnant and they're on a stable regimen, I would not push to switch, especially since we now have some data suggesting that bictegravir FTC is safe. Yeah. And we have this good PK data as well. So I will do exactly what you just described and encourage them to attend to other antenatal issues.
All right. And then cycling back to one more study of injectable therapy. Babafemi, take us through the jabs trial.
One interesting thing about it is I was trying to figure out how they came up with jabs. And if you look at it, it's really quite a stretch, but the name gets 100% because in fact, what they did was to look at the implementation of long-acting cavelpipirin in a population that is typically that's enriched with individuals that are normally excluded or underrepresented in clinical trials. Also, these individuals had complex medical needs, which they demonstrated when they looked at certain metrics such as such as social isolation, polypharmacy, use of drugs like methamphetamine, mental health issues, etc. And at 48 weeks, the results were good because 97 of the participants actually got the injections within the 14-day window. So plus or minus days from the target date. Over 80% got it on the target date. And when they looked at virologic outcomes, nobody had virologic failure. There was only one participant who had viral load of 55. Overall, really good study, expands the population that in whom clinicians should consider using long-acting cabotegravir and will limit or reduce that tendency to just dismiss some individuals as, oh, you have complex medical needs, therefore you're not a candidate.
Great. Well, listen, Babafemi, I enjoyed this discussion. And once again, we have been looking at the third quarter and highlights in HIV medicine for this quarterly brief. I've been joined by Dr. Babafemi Taiwo from Northwestern, and I hope everyone has a great day.
Cheers, Paul. Talk to you next time. Bye.